Okay, good morning and welcome everyone to the latest in our Talking Health discussions. This morning we're focusing on the NHS and we're looking at a case study, doing more through continuous improvement, the London North West Hospital story. My name is Astrid Spink and I am the Sectors and Communities Manager for the public and health sectors in the UK. Today's speakers are Shekh Motin, Deputy CFO at London North West Healthcare NHS Trust, and James Biggin-Lamming, Director of Strategy and Transformation, also at London North West Healthcare NHS Trust. I will now hand over to Shekh to start this morning's discussion.
Good morning, everyone. Thank you, Astrid. Very helpful. We'll go through a few slides, me and James, and I think it'll be really good, given it's a talking series, to have a Q&A and good conversation. So we're probably about 15-20 minutes. If you have any urgent question, please feel free to ask. If not, then we can leave that towards the end. So as Astrid said, both of us are from London North West University Healthcare NHS Trust. It's a mouthful, isn't it? Hospital in northwest London, in the Gardens of Harrow. Then go on to the next slide, please. So what I'll do is I'll just talk through very quickly who we are in terms of a hospital. So we're an acute hospital provider, relatively large organisation, very complex, and recently, over the last 12 months or so, we've come together with our other acute partners within northwest London. And we currently have a board in common. So between us, we look after a large population of northwest London. Within London Northwest Hospital, we have just over 8,000 colleagues who work for us. A lot of them actually live locally, and we serve a very, very diverse population of around 1 million, which is about 50% of the northwest London population. And interestingly, about 3/5 of those that population is from an ethnic minority background, which we extremely take into consideration when we're looking at how we develop our services and meet the needs of our population. We're also a teaching hospital. We train clinicians, working with both Brunel and Imperial College, and we're active in research. There are 3 hospitals, physical hospitals within the hospital group: Central Middlesex, Ealing, Norfolk Park, which is one of our busiest hospitals, and it's also one of the busiest A&Es in London, if not the country. St Mark's Hospital is a specialist centre for colorectal surgery and medicine, which is currently based at Central Middlesex Hospital. So that's kind of the London North West Hospital. And over probably last 15 odd years, the 3 hospitals came together for a series of mergers, last one being about 2015, I believe, 2015, 2016. Here's a range of all the services that we provide, and I've just added a few in blue towards the end. In the last couple of years, we've invested heavily in a elective orthopaedic centre across Northwest London, where we host it on behalf of Northwest London system. And we've heavily invested in a community diagnosis centre as part of the national programme, which is opening in April. And we're working on an ophthalmology diagnostic hub, again, for Northwest London system. And that's quite important when I come back to in a minute around the history of Northwest London hospitals. And this is where we sit. So if you were looking up in the map of the country, somewhere in London on the northwest side, you'll see a map like this with the boroughs. And the 4 acute hospitals, London Northwest, Chelsea and Westminster, the Hillingdon and Imperial. Imperial is a very large academic health science centre as well, and a very tertiary hospital, as well as Chel West. And the 4 organisations have been working together. And you can see how the geography of Northwest London, which is about 2.3 million people who live there, how is served by our hospitals. Some are very close. Important slide for us, because that's what we're trying to do, is work much more collaboratively in how we get the most out of the services that we have without duplication. A lot to do, and that's both on clinical and non-clinical. So finance professionals, there's a lot of work in corporate functions like finance, HR, And recently we collaborated, put together a hub for all our procurement services for the Northwest London system. James. In terms of performance, I think I've kind of split it between pre-COVID and post-COVID. As I mentioned earlier, the trust's been through a series of mergers, 2 in the last 15 years or so, and I called it a failed but unsuccessful system reconfiguration, which is quite large in Northwest London, under the banner of shaping the healthier future, which is partly related to how we provide large-scale care outside the hospital. And that is something that we would revisit again, but the system was quite challenging over the last few years. So it was also a very financially challenged organisation, but in a financially challenged healthcare system in Northwest London. Both the commissioning side of the NHS and the provider side was quite challenged pre-COVID, partly because of slight underfunding relative to other systems, and partly because other issues, both structural and flow of patients. In 2019, and I'll show you a slide on the money where we are at the moment, the trust clocked up circa about £100 million deficit. The underlying deficit still continues, although it's coming down thanks to some of the work that James and others have been doing. Capital was very much constrained, very little investment. So if you turned up in one of our buildings, certainly Northwick Park, you'll see there's a huge amount of backlog maintenance that are still there that needs to be done. People are very important. I mean, as an organisation for about 5 to 10 years, because of the financial constraint and performance constraint and where we are, there's been a lot of toll on people, the pressure on all our staff, and then COVID hit, which was quite challenging for Northwick Park, certainly as the front line of first wave of COVID. And at the time, we were in one of the bottom tiers of the NHS performance regime. Key drivers of the deficit were threefold of that 100 million, and there was an external review done about 2018, 2019, which says about a third of it is probably structural NHS, and you'll see that in a lot of the district general hospitals or hospitals which are just on the outside of London, where the portfolio of mix is not quite balanced like some of the central London hospitals, which the old national tariff system didn't favour those type of organisations because of the mix. So it's a structural problem. There's a local problem in terms of the flow of patients, the demand, the A&E demand that comes through. And as I mentioned earlier, the healthcare system was quite challenged. So there's about a third of the problem is there. And there's probably roughly about a third of it is actually the problem within the organisation of opportunity to be more productive, more efficient. And when you compare unit cost, relatively it was quite higher compared to others. So there's an opportunity for us. Post-COVID, as I've mentioned, very difficult COVID experience. Many hospitals went through that. Northwick Park was the first wave. They had to close down for a few weeks in the first wave. Rebuilding the leadership and capacity, Jeb's going to touch on that, so I won't go through too much on that. And through James and colleagues, we've been looking at medium-term improvement, which is where the London Northwest story is about sustainable change, continuous improvement, as opposed to constant turnaround. People are feeling much more confident, much more willing to change and adapt. When you come out of turnaround, that's quite a big ask, and COVID. So we're seeing some of that green shoots. Financially balanced for the last 3 years, not to say it's quite challenging. Certainly this year, delivered the efficiencies of 3 to 4% pretty much every year for the last few years. And we're getting to that £1 billion organisation in terms of how we attract investment into the organisation. From a capital investment perspective, on average, we've been spending about 70 odd million over the last 3 years, compared to pretty much nothing 4 or 5 years ago. So we've been very good at attracting investment from the NHS because of our success and grip. And I won't go too much into the NHS context. I think most of you know the NHS financial regime with the new ICS, the ICBs or integrated care boards, and the regime moving away from a payment by system to a payment by something else system at the moment. a mixture of complexity that doesn't help. So the future is quite difficult to predict on the financial regime. Nonetheless, I think as an organisation, we've got to grips with that, and we're working through with our partners to navigate through the future. James. So just to finish, so for me to finish off and just pass it on to James, who'll talk more exciting stuff about the journey. You can see that for the 22-23, 21-22, I'm not counting the COVID period, we've broadly delivered on balance on our performance against our statutory target. And 23-24, we have submitted a balanced plan. We continue to forecast we'll be on balance, but like the rest of the organisation, will be quite a challenging period from now onwards to March. So I'll pass on to James, who's going to talk about our transformation journey, where this is how we achieve the financials.
Shekh highlighted that we came so pre-COVID, we're in financial turnaround, and one of the challenges there is the external colleagues who come and offer advice, but actually then telling the rest of the organisation what we have to do, what we can't do, and that impacted the confidence. Coming out of that, one of the changes, and this was just before I joined, was the decision to invest in a transformation programme. And the idea of being here that we needed our staff to come with their ideas and use their skills to improve how we're working as an organisation. And before COVID, we had, or the team had trained hundreds of staff on continuous improvement, areas like lean, and we're doing some of the yellow belt and the green belt training. And there were lots of good ideas, but smaller ideas sort of within services about how to improve. Coming out of COVID and in a wonderful fit of career timing, I joined in February 2020, just as COVID was hitting the trust. We changed from lots of small projects. Actually, there were some big strategic things, and there was a small resource for around 10, 12 of us in the transformation team who were then able to go and support some of the bigger projects, and that was moving our services around, helping get the pathways set back up, really launching same-day emergency care, and that confidence to sort of go where things were strategically important, then grew. And one of the areas we were not doing so well is linking with our clinical divisions, and that's where a lot of our services are run and sort of the day-to-day within the organisation. So the next year we expanded our investment. Rather than going and bringing more project managers and people with experience outside the trust, we created something called the Transformation Fellows, which was a 12-month secondment for people to come and work with the transformation team. There's our staff. We've had nurses, we've had pharmacists, we've had therapists, we've had managers, we've had dietitians, so a whole range of people from across the trust. They are hired on aptitude, so they're showing a high degree of background where they've been trying to improve quality, and the services locally show that they're a local leader and are some of our high potential staff. And they've come and joined our team for a year. They get lots of training and support, and we ask them in return, they're our link with clinical divisions. So they're briefed to lead some projects within the division, to coordinate the rest of their programme, and then help engage and support the training of the staff on continuous improvement. And that really boosted what we did with first cohort, that rather than just be the strategic, linked to the strategically important things, we're then increasingly a platform across the whole of the organisation. And we started introducing some of our systems and processes, an online project and benefit tracking system we've built in-house collaboratively with our partners at Imperial called Track It, which I'll touch on again later. And then from that, we've just grown and grown. So they had our second cohort of Transformation Fellows last year. We're now on our third cohort. The ask each year has grown bigger, but we've worked ever more closely with the finance team. So as well as productivity improvements, where we can point to where we've avoided costs or where we're delivering more of the same, increasing our focus is actually on the cashable ask as well. And our determination to do that in a joined up way is when we go and say to our staff, we need to improve things, we didn't want to go and say, we want you in this meeting talking about cost improvement, this other meeting about quality improvement, and this other meeting about staff improvement. Actually, we wanted to think about things in the same way. We know if we get things right first time, we reduce the waste in the pathway, we would help make our staff life easier, our patients' life easier. It takes less resource to deliver the same, and that's where the cash starts falling out. We've seen that gain and improvement and engage our staff in the same way, because we're able to talk about quality improvement and what we want to improve, not just what can we do without, what do we need to cut. Against this, this has been our sort of philosophy or link. So our team is divided. I think of it like a pyramid. We have a few big strategic projects across our trust and with our partners. Areas like the elective orthopedic centre we've built in collaboration with other acute hospitals locally. That's led and resourced by experts, people who have their full-time role within the team. We then have our numerous medium opportunities in the NHS we call a cost improvement programme. So these are things within the service around smaller changes, but we need to make sure they're happening. And that's where our transformation fellows and that support into divisions goes. And then hopefully, and this is where we're seeing it sort of grow and grow, lots and lots of quality improvement initiatives, some of which I know about, some of which I don't, but it's about changing some of the culture to encourage staff wherever they are to try and make tomorrow a bit better than today. And we do that with training support led by everyone in the team, and also what we call our improvement network that meets regularly and that provides some of that support. Across all of those dimensions, we've got a PMO to track what's happening and give people a single list of everything that's happening, so it's not chaos all over the place, and seeing what's happening with the benefits. And we've got ever more sophisticated with how we're doing that in a proportional and effective way. We have a QI method and training and tools we use, and analytical support with our team centrally to sort of focus on some of the improvement dashboards. We work across some of what we call cross-cutting. So these are things that impact the whole of our organisation in different ways. We need people working across our divisions, working differently, as well as within different areas. That's our divisions and our corporate, where it could be a change within the service. It doesn't have dependencies on others, so they can get on with it, but we want to track it and encourage it and support it in the same way. And all of that then is governance to think about as an integrated approach. Our mandate, our direction is set by our trust executive group. That's the most senior sort of management group, short of the board in the trust. And we have a transformation group that meets once a month that is overseeing the programme, setting its targets, monitoring against our achievement, hearing and managing some of the interdependencies between work streams. That's chaired by our CEO, which helps emphasise the importance, and the visibility helps to get some things unblocked very quickly. We have a patient representative on it, as well as the SROs, the senior leaders of the different work streams, because it's at that meeting we're asking people to come along with the problems they can't solve locally, as well as saying we're on track or not, get them to share what they need, and so we can help balance that out if one division might need another division to do something different, and it's that progress isn't happening outside. Underpinning that, we have an online program tracking system. There were lots available on the market, and we were looking at some of these just as I joined, because rather than a sort of industry of Excel templates and Excel files that float around, we wanted one single version of the truth. We built it within Microsoft Power Apps with our partners at Imperial, who we did a lot of work with, and that's really helped the consistency of our learning and our sharing. And for example, last week we were sharing all of the different improvements we'd done within our trust, so that others locally, because actually that might help for us, and then we can share all the materials because they're all on the database ready. The system allows us to give a single version of the truth, so it goes into a weekly dashboard we share around, so everyone can see in aggregate what's happening, as well as the detail of individual projects. That track it system is underpinning the papers and what's happening within the divisional corporate improvement. It's set up so project managers can be adding their information, or project team members can be adding information all in the same place, and so that's what's checked monthly at the sort of more detailed meetings, and the same with our cross-cutting work streams, where it's cutting across, and all of that then feeding in each month the transformation groups. So that's the circle about what's happening. This is an example of the dashboard we're sharing regularly. And what we've done here is we've said part of our mantra was, we want to help patients, we want to help staff, we want to help our use of resources. And so we track, we have a target to impact 1 million patients, 42,500 staff, that's each staff being impacted by 5 projects on average, and then our overall savings identification. So that's where we start at the top, and we encourage for each of our projects, well, what's the magnitude of patients you're impacting, what's the number of staff you're impacting, where you can, when a project moves past an implementation stage gate, so we've actually implemented it, we ask people just put an estimate of the number of patients this is making a difference to, and that helps keep us honest, because you measure what matters. If we're only measuring the money, that's all we'd be saying that matters, and actually it's giving us the balance between, are we helping our patients and our staff, and sort of highlighting right now probably need to do a bit more on the things that are helping staff against our target, as well as how we're doing sort of identifying value, and then really getting into the nitty-gritty, being able to forecast that month by month, and the actual delivery of that. And productivity, which we track, so sort of non-cashable benefits, but thinking about those as well. And this data as well helps, you can filter it for your division or different work stream to understand what's happening locally, as well as that overall picture of the trust. These are some of the words. So within the system, we ask people to say what are the benefits of the project as they get it started, and these are some of the things that come out that colleagues have described across the hospital. So very, very rich, but also very focused on patients. Although we're making sure we're seeing the money fall out, it is by providing better care to patients, a better experience to staff. We believe that's where it's been successful. And some examples of recent projects that help with that. We've sent, when we moved on some of our services for COVID, we had space we could refurbish. And rather than just using it as general outpatient rooms, we had urology and breasts, which are two of our really fantastic services, punching above their weight. We refurbished it as one-stop shop areas, so it allowed innovative pathways, it allowed the teams to come together and work collaboratively. It was a much better experience for patients. So if I use breast as an example, patients on their pathway to get treated for breast cancer might visit 3 different sites across our hospital, depending on what the different clinic or the need was. Even when they were coming to one of our sites in Northwick, it is a bit of a monster of a hospital. It's huge, and they'll be walking from one end of the hospital to the other to get a diagnosis, to go and get for the sort of radiology, and then going back to see the breast consultants. Now it's all in one place, and is much better experience. Other areas, virtual wards. We've seen a number of different pathways being really successful. We have about 80 people on our virtual wards at any one time. It's helping us avoid beds, and we've got some wonderful patient stories, and it's really helped them engage in understand their disease and how to control it in a way they've never had time to have those conversations. But they have, the virtual ward creates some space for our specialist nurses. Rehabilitation is some of our St Mark's team, where they have come and said, to do some of the really big complex operations, you need to be fighting fit. It's like running a marathon, and having people come along when they're not doing that. That's why they're in intensive care longer. That's why they're staying in hospital longer. If we can work with local physios and sort of gym trainers, depending on what the sort of range of needs are, we can get you as fit as possible, so you'll get more likely to be successful for the operation, and we're seeing a reduced length of stay. And have better outcomes for patients, not just for the operation, but it's encouraging those healthy habits around eating, around exercise, around reducing smoking for that long-term gain. Some other projects here, we're happy to talk about more examples later. That's sort of a range of richness we do across the organisation. But our team is all over the place, and sort of a much longer list of projects here, different benefits around productivity, around safety, around quality, around patient experience. A lot of what I focused on is sort of the strict project management, but we do encourage improvement training across all levels in our organisation. Opportunity for people come online to read about it. We've had real take up in the past couple of years, moving to what we call our bite-sized courses. So it's an hour a week over 6 weeks over lunchtime to come and learn about project management skills or improvement leader skills, and different tools people can apply. The Improvement Fellows is over 3 months, and you do some day-long workshops, but then are putting that into practice with a project within your service. And then our Transformation Fellows that I described earlier, so the most intensive. And colleagues who come through that programme, most have 2/3 of them have been promoted to a more senior role, either in the organisation, a couple in other nearby organisations. So they're taking the skills they're learning and then going back and acting as stronger leaders, helping embed that across our organisation. So with that, I'll hand back to Shekh for the final bit on looking ahead before some questions.
Thanks, James. That's really helpful. So certainly the last one is quite important, which is a difference from just pure turnaround. It's about how do we build the resilience within the organisation and train people so they are multiplying certainly the fellows and the skills that when they go back and share with their teams. In terms of looking ahead, I think some of these are fairly obvious. Certainly this year and ahead, the NHS is back in financial constraint, and we're no different as an organisation, as a system. The industrial action played a big, huge part certainly for us and others, more so for us in recent months. And as you know, it's ongoing this month and in January. This year, inflation hit us all. The hyperinflation, although it's now down, but a lot of our cost in utilities in some of the contracts that we have are significantly higher than what the NHS funding is there for. So that's causing a bit of a problem that we will need to manage. And our challenge, I think this is at NHS level, and we're no different. And this is where the good work of James and team and others are really helping us in terms of improving our productivity, because we're still recovering from COVID. And those challenges remain unchanged, but equally they are opportunities as well. Emergency demand up, elective demand up, 7 or 8 million people waiting for elective surgery across the country, and we've got similar issues locally as well. And one of the biggest challenges, I guess, post-COVID is certainly where we are competing with others on staff. Is the workforce. We have huge number of vacancies, certainly in specialist clinical areas, which is quite difficult to recruit and attract people when you're in borders of London and the home counties, because you can easily go into central London. But we're working through that with our acute collaborative partners. People very important, and happy people means happy services. So we continue to work on the OD aspects of our teams, supporting them, training them. As I've said, we can't. There's not many people out there, and we are recruiting internationally. So we need to get more out of the people that we have in this country. Technology will play a big part. We've just implemented a new electronic patient record system, and that is going through its phases as they do. But that's a big change for us as an organisation to modernize, because we've been working very, very old systems. Give you an example, I think about 40 or 50 odd systems they need to pull together, and this will replace a large chunk of those. Provider collaborative benefits are the scalable benefits, how we work together, share resources, not duplicate, provide single point of contact, a single services like the elective orthopedic centre, the urology breast centre that James talked about, but also not limiting to just clinical services as support functions. I mentioned we combined our procurement services across Northwest London. We want to be doing the same with all our corporate functions to get the most out of it at scale. And financial leadership, this is an ACCA talk series, so it is important. I think this is one that I think about a lot, is how do we skill up finance professionals at all levels to adapt to this new regime, the new change in the health service. Requires much more than just counting the numbers, because ChatGPT can count the numbers and others. Is how do we go beyond that and work in partnership like we do with James and his team and our clinical and operational team, more on the partnering side to improve the organizational opportunities and performance. That's something that worth Astrid taking back to. I talked a lot about business partnering in ACCA, and I think that we just need to adopt that more with the changing landscape. And ever-changing NHS financial regime as well as the structures, that doesn't help. But I think a lot of us who've worked in the NHS for a very long time, and certainly in public sector, would know that just like industry, your market change, your policies change, regulators change, and anticipating that change, working to it. Otherwise, it's quite difficult to plan. But certainly that is an ongoing change every year, every couple of years, every 5 years. And continuous improvement, as James described. We want to continue on that journey. We have a really good, committed leadership, both at board level and management, and the courage to take time to make that sustainable change rather than short-term cuts, as they call it, which is what used to happen in the past. And we've seen the fruits. It's having that courage to continue with that, which requires leadership. Okay, so I think that's the. I'll leave that one. That was about a strategy. So we'll open up to Q&A if that's okay, Astrid. And thank you to everyone for listening.
That's great. Thank you both, Shekh and James. Very interesting. Thank you for the kind of initial overview, Shekh, in terms of, the size of the hospital trust and how many different hospitals have been brought together and the merger and the different populations you have to serve. And, interesting to hear that you were part of, hit very hard by the first wave of COVID. It's interesting also, James, that you were saying that instead of bringing in external help to turn things around, it's actually using the people within the trust. And that's interesting in terms of how your word cloud demonstrated that people felt things were better for patients. There was a lot around patients, improvement, and staff. So it's really listening to staff, working with them, collaborating with them. And these transformation fellows sounded like an excellent opportunity in terms of listening to staff, taking on board their ideas, but also giving them the structured training behind their thoughts and ideas to then be able to go on and be promoted, as you mentioned. In terms of the future, Shekh, absolutely, there's always going to be continual change. Change is a fact of life in the public sector. But as you say, it's good to anticipate it, to work with partners, to avoid duplication. And you both mentioned how important it was to have good leadership at the top of the team, clear communication. Your group was led by the CEO, which gave a good message in terms of leadership behind this. And we have clear communication with staff across the hospital. So thank you very much for that excellent summary. Really good case study.